Good evening and welcome to Doctors on Call. I'm Dr. Ray Christensen from the Department of Family Medicine and Community Health at the University of Minnesota Medical School Duluth, and I'm your host for tonight's program on men's health. We will be glad to take your questions on impotence, incontinence, prostate, and other kidney and bladder problems. Remember, the success of this program is very dependent upon you, the viewer. Please call in your questions and we will do our best to address them. The telephone numbers for your questions can be found at the bottom of your screen. Tonight our panelists include Dr. David Hutchinson, a family physician with St. Luke's Lester River Medical Clinic in Duluth, Dr. Paul Tonkin, a urologist with Essentia Health in Duluth, and Dr. James Vodvarka, an internal medicine physician with St. Luke's Hibbing Family Medicine Clinic. Our medical students answering phones tonight are Dan Dutcher from White Bear Lake, Minnesota, Eric McDaniel of Ontario, California, and Marie Whippler from Parkers Prairie, Minnesota. And now on to tonight's program on men's health. Dr. Hutchinson, why don't you start out and talk to us a little bit about your concept of men's health?
Thank you for the question, Dr. Christensen. I think of men's health across a continuum of ages, from childhood through adolescence and young adulthood and middle age, and then the elderly. And health risks and health concerns, of course, increase with age, and many of our patients and concerns come from the older age groups. Some of the major health risks we see in those age groups would still have to be some of the common ones that you'd expect. Heart disease, cancer, and accidental injury and death are the major health risks to men's health in general.
Dr. Vodvarka, are there some things that we can do to offset and avoid some of those problems as we age?
Well, one of the biggest things in men's health that we can avoid is people, especially on the iron range. I see a lot of people that smoke cigarettes, and men's health, just like women's health, a lot of the things that we see associated with men's health is related to vascular disease, and smoking is a very high contributory factor to vascular disease. So that's one of the biggest things that you could avoid. Proper health care in terms of diabetes, hypertension, and cholesterol is another big factor in men's health. And if we can make our yearly visits to our doctors and get things checked appropriately, we could avoid problems in the future.
Go ahead.
Well, so Dr. Vodvarka, you bring up so many good points, and they really highlight the general point of about the importance of lifestyle. Healthy lifestyle is ahead of anything else that people can do for themselves or that doctors can do for patients, a primary treatment for health maintenance. You talk about smoking and management of cholesterol, and it really, I think in general, highlights the importance of doing all the things that we can do to be healthy, like eat properly, eat moderately, avoid smoking, as you say, exercise. Eating moderately and exercising would be the main things that men can do to stay healthy and highly functional and free of symptoms till later age.
It's a good point, and I just want to jump in here and bring it to a different side of the coin here. I often see people once they developed a problem, not on the primary care side, and really smoking is a huge problem in men's health. For example, a man who develops blood in the urine, that's in a smoker, that's bladder cancer until proven otherwise. And so many times I'll see a gentleman who has a new bladder tumor, and I'll say, are you aware that smoking is the #1 cause of bladder cancer? And they say no. Everybody knows that smoking is related to lung cancer. What they don't realize is that really the lungs is just a huge network of blood vessels, and the toxins from the cigarettes get into the blood via those blood vessels, filtered by the kidneys into the urine, and it sits in the urinary bladder for a period of time. And if that goes unchecked, have a major life risk on our hands. So it really goes back to an ounce of prevention is worth a pound of cure. If we can stop the smoking to begin with, or stop it early, there's real benefits.
In terms of bladder cancer, you hardly see anybody that has bladder cancer that didn't smoke.
That's exactly right.
Yes.
Yep.
And bladder cancer caught early is treatable. Once bladder cancer metastasizes, its prognosis is very bad.
That's right, and so that's a good take home for our viewers, especially our middle-aged to older men. Blood in the urine for a man is never normal. Probably deserves a urologic workup.
So you're a urologist, Dr. Tonkin. What does a urologist do?
Well, we really do specialize in men's health. Of course, we see women and children also, but we really manage all elements of the urinary tract. So everything from kidney tumors to kidney stones, to enlarged prostates, to prostate cancer, problems conceiving children, male infertility, for example, and then things like medical to surgical erectile dysfunction also.
So we've kind of been talking about risks to men's health, and one of the questions summarizes this pretty well. What are the main risks to a man's health over time? So just in summary, I heard diabetes, and I heard smoking, exercise, lifestyle.
Yeah, so when I think of risks, I think of disease processes or reasons for dysfunction and lack of health. So heart disease, cancer, accidental injury are the major risks to men's health through middle age and older age. And young age, yeah.
Diet?
Diet's a big factor. Low fats, low cholesterol diets play a big role, I believe, in men's health.
We've had some questions about impotence come up. Jim, we talked about impotence a little bit earlier. Do you want to describe that for us a little bit?
Basically, in a man, impotence is a lack of being able to achieve an erection during sexual intercourse. And back in the olden days, we used to think of impotence as more of a psychological problem. But over time, with the emergence of phosphoesterase inhibitors, we see that there's a big organic problem to impotence. And Viagra kind of revolutionized this country in terms of impotence and being able to achieve more sexual activity, and especially older men. When you talk about impotence, if you look at impotence in general, I guess by the time you're 50 years old, I guess there's a 40% chance that you're going to develop impotence. And at the age of 50, as you get older, every decade impotence increases by another 10%. So it's probably something that every man's going to face over time. Just like prostate cancer, I was told by urologists where I'm from in Pittsburgh that prostate cancer, when you're 50 years old, there's a 50% chance you have prostate cancer, and every year you live, you have a chance of developing prostate cancer by 1%. So I guess when you're 100 years old, there's a pretty good chance you got prostate cancer.
That's true, and I hear that a lot from my patients. Isn't it true that if you live long enough, you'll get prostate cancer? And I do think that is a true statement. However, that data came out of cadaver data. So, for example, those aren't guys who are developing symptoms from their prostate. Those aren't guys who have an elevated PSA, who have a bump on their prostate in an exam. Those are guys who died in a car crash, heart attack, stroke, and at autopsy had some small focus of cancer in their prostate. So there is a difference between cancer at autopsy versus your doc picking up on something. Prostate cancer still continues to be a serious problem, 35,000 deaths annually. The problem is what can we do to detect it? Really, what can we do to detect clinically significant prostate cancers? And that's the big challenge today.
One of the questions is PSA, and a lot of people think that if you have a high PSA, that it means you have prostate cancer, and that's not true. A PSA is pretty much a screen that can be elevated for other reasons, such as prostatic hypertrophy. And probably one of the most frequent consults you get as a urologist is somebody's got an elevated PSA.
It used to be.
Right.
Yeah. Yeah, there's been different guidelines in terms of, who should get a PSA, and just as a take-home point to our viewers, the American Urological Association is encouraging conversation between the patient and their primary care doc between ages 40 and 50, talking about the pros and cons of PSA screening. American Cancer Association has a very similar recommendation. The United States Preventive Task Force recommends no PSA testing. But I think the bottom take-home point is, you should see your doc, talk to them, and at least have an engaged discussion about it.
Hutch, another piece that comes up that we didn't address is alcohol.
Exactly right, yep. And its contribution to obesity, its contribution to other mental health conditions, its contribution to inactivity, and its contribution to accidents, disability, and even death.
Is there any contribution with alcohol, or does alcohol cause any problems with the GU system, the kidneys, bladder?
I mean, certainly alcohol is a diuretic, so from a standpoint of urinary frequency, urinating at night, those are things are related. There is some connection between alcohol dependence and abuse and erectile dysfunction as well. Those are probably the main links, in my opinion.
Heavy alcohol use can also lead to low testosterone levels, which can contribute to depression and low energy and
Erectile dysfunction.
and erectile dysfunction,
Yep.
exactly, to bring the conversation full circle.
You're right.
So Hutch, is there some way that a person can get back into shape?
Absolutely. I appreciate that question. That's an increasingly common one, which I'm happy about. It's harder in middle age or older age to get back into shape, but it's an important endeavor. It takes longer to get back into shape because our recovery time is longer. It takes longer to recover from an exercise session or a workout. And so it becomes important to develop more than one kind of exercise that you're trying to use in order to get back in shape so that you can cross-train, and that way you're at less risk of overuse type injuries or which would get in the way of a reconditioning program. And it's important to combine both cardiovascular fitness exercise, or cardio as people call it, with resistance training or some light to modest weightlifting. And combining those forms of exercise in a consistent way, in a gradually increasing program, especially under the guidance of a personal trainer or some sort of coach, absolutely, people who are middle-aged or even older-aged and feel out of shape can significantly increase their fitness levels.
Paul, undescended testicles. A person had a correction at age 11. What is the outcome on fertility, and has the treatment changed over years?
The treatment of choice for an undescended testicle is still to bring the testicle down into the scrotum at a young age if possible. I think what's changed maybe a little bit recently is how quickly do you bring a testicle down into the scrotum. Some pediatric urologists are recommending doing that before age 1. And so that's been probably a change. From a standpoint of fertility, it's been shown that men with 1 testicle have equal fertility as men with 2. Now there's been some thought that maybe there's some reason why the testicle did not distend naturally in the first place, which might suggest there's a problem with the testicle that was down at the time of birth. But generally speaking, as a take-home point, if you have 1 normal functioning testis, you probably have equal risk of normal fertility as compared to a man with 2 descendant testicles.
Jim, are there any immunizations men need to consider having, and at what age? And Hutch, you can jump in here too.
Men should have flu shots every year, as long as you don't have an egg allergy. Flu shots, as we see in Minnesota this year, I mean, the flu's unbelievable. I've been practicing medicine for over 20 years now, and I've never seen a flu season as bad as this one since I've been practicing. I worked in an urgent care the other day, and it was last week, and I think I tested 45 people for the flu, and I had 31 positive tests, and that's like, usually you see about 10%. So I mean, the flu is really a bad thing this year, a bad disease, and I mean, most people don't get to the point where you're going to die from the flu, but you can get pretty sick, and if you have comorbidities such as asthma or COPD, it raises the risk factors of something bad happening. Other things for men to consider when you reach the age of 65 years old, I mean, the shingles vaccine is I think it's one of the big things over the last 10 years that we've seen come out in vaccinations and preventive medicine. And I don't know how many people that are watching tonight had shingles, but if you get shingles and you get post-herpetic neuralgia from shingles, it's a very severe disease, and it can be very painful and very debilitating. Anybody that has asthma or COPD should have pneumovaxes. Pneumovaxes should be given to anyone 65 or older at least once, even if you don't have asthma or COPD. But just looking at the prevalence of pneumonia over the last several years, I mean, we're getting more resistant strains of pneumonia coming out, and if you could avoid getting it at all, that's prevention is the best medicine.
And both men and women should talk to their doctors about tetanus updates and whooping cough updates, and those two things come together in a single booster now called a Tdap. One new immunization recommendation over the last several years pertains to boys in particular, and that's for preteen and teenage boys to consider protection against the human papilloma virus, a virus that can cause venereal warts and that can lead to cancer of the cervix in women. And boys can now receive that 3-part vaccine series starting at age 9 over the course of a year.
That vaccine goes up to the age of 27 too, right?
Right.
So Paul, you've brought some things for us to look at. So let's go to erectile dysfunction. I think we've kind of beat around the bush as to some of the causes, vascular and otherwise. So do you want to talk about it just a little bit?
Absolutely. I mean, erectile dysfunction, as you mentioned earlier, is very, very common. And I think the workup should probably start with your primary care doc, reviewing your medication list, making sure there's no medicines that could be removed or changed to help with erectile dysfunction. Certainly we need to be thoughtful about, could there be underlying cardiac risk factors here? From a standpoint, could erectile dysfunction be kind of the tip of the iceberg or maybe some ongoing heart problems? But once you've ruled out those things, you need to get to the heart of trying to treat things, and certainly the use of some of the drugs in the market are very effective. But when those drugs fail, or if they fail, there are other options available. And for example, there's a vacuum pump device, which is an external device, a non-surgical device that works quite well. Then there's penile prosthesis, which I did bring one along. If we can maybe zoom in to take a closer look, I can certainly point out some of the componentry here. And this operation is done through about a 3-inch incision in the perineum, which is the area between a man's legs, and in the scrotum area. And so there's 3 pieces to it. One is a reservoir of fluid, and this, generally speaking, is behind the pubic bone, buried in the deep abdominal tissues. There is a pump, which is placed in the scrotum, feels kind of like a small third testicle. It's usually very superficial, so the man can feel all the componentry very easily. And then the cylinders, which are actually placed in the penis itself, and this is an operation that's been around for a long time. It's been basically tried and perfected over time. Success rates are very, very high, about a 90% success rate. Patient and partner satisfaction rates are also around 90%. And I think what's really changed here in the last 5 to 10 years is that the infection risk has been driven way low, about 1% risk. Almost all the componentry is usually coated with antibiotic sort of material. And the nice thing about this is that when it's inflated and activated, it's very rigid and natural feeling. And when it's deflated, it's very soft and also very natural feeling in the the off position or the soft position. And so those are some newer things that are available for erectile dysfunction. And these are things that can be offered locally in Duluth for sure. The other piece that kind of goes hand in hand with erectile dysfunction, certainly after prostate surgery, the 2 main side effects of prostate surgery for prostate cancer are erectile dysfunction, which we've talked about, and then urinary incontinence. So I'll shift gears here a little bit and talk about some treatments for male incontinence after prostatectomy. Certainly a man should learn how to do Kegel exercises, which is an exercise that most women know how to do, where they squeeze their sphincter muscle to strengthen it over time. But if those fail and the man still leaks urine and is wearing pads or diapers after surgery, this is really the gold standard for that. This is called an artificial urinary sphincter. Again, there are several components to it. If we can zoom in here, this again is a pump that lies in the scrotum, a little bit smaller than the other pump that I showed earlier. There's a fluid reservoir, which again is quite small. That again rests behind the pubic bone in the abdomen. And then this small cuff, and this essentially, once it's put in the patient, wraps around like a ring around the urethra. And so as a man is going about his daily activities, this is inflated with fluid, thus pinching the urethra so no fluid leaks out. When he needs to urinate, because his bladder will still feel full, basically squeeze this one time, the fluid comes out of the cuff, allowing urine to pass. The cuff automatically refills with fluid within about 60 seconds, and you kind of go about your business. And again, success rates with this operation about 90%. It's not for everybody, but it's a good option for a lot of men.
Makes me think back to the old gentleman I took care of when I was back in medical school, so we're getting way back there. And he used a spring-loaded clothespin.
Yep.
He had it set just right.
Yep. An external device.
An external
Yeah,
device.
those still exist.
I was happy that Paul mentioned the medications and the rectal vacuum pump device too. Patients are so happy with those most often, and as initial and inexpensive treatments. They've been wonderful advents, and medications have made it such an easy place for us to start.
Absolutely.
After surgeries like prostatectomy, I'm sure you end up with higher frequency of the more advanced treatments for erectile
Absolutely.
dysfunction.
And again, as a take-home point to our viewers, you really can't treat your issues or problems until you bring them to your doc. And a lot of times, patients trust their family doc even more than their surgeon. And so, a lot of times, it's most appropriate to start the discussion with your primary care physician.
So let's move back upstream. Hutch, there's a complaint of getting up frequently at night to go to the bathroom. Should this person be concerned about prostate cancer?
Prostate cancer would be one consideration with a symptom like that. Much, much more common would be simple benign enlargement of the prostate gland. The prostate gland naturally enlarges with age, and as it enlarges, it compresses the prostatic urethra, as the urethra, the tube that leads from the bladder to the outside through the penis, runs through the prostate gland. As the prostate expands, it compresses the urethra so that the conduit, or the hose, if you will, has a narrower gauge. And it becomes more difficult to empty the bladder completely, and to empty it with the same force that you had as a young man. So virtually everybody, all men's prostates enlarge with age, and some enlarge to a point where it's difficult to empty the bladder completely, and so you end up needing to void more often, including at night, which leads to getting up at night.
So what do we do about big prostates these days?
Well, that was very well said, by the way. Usually we start with medications. So medications that relax the muscular component of the prostate to kind of allow that area to spring open, so that channel, even though it's tight, is a little bit less tight, and that often improves urinary flow. There's also medicine on the market that allows the prostate to shrink about 30 to 40% by volume over time. And so those are really the two mainstays for medical therapy. If those fail, there's a surgical option called transurethral resection of prostate tissue, abbreviated TURP, which is a very effective way to basically scrape out the inside of the prostate tissue and open that channel up widely. It's again, that operation's been along for a very long time. There's been a lot of experimentation with different techniques on that concept, and it seems that every year we meet as a national convention, everybody goes back to saying you can't beat a good old TURP, just going back to the tried and true method, and patients do very well with it.
Patients are very happy with that surgery. We used to do so many of them, but now the medications work so well as an initial treatment that people getting to the stage where they need an operation like a TURP or a transurethral resection is.
So Jim, another question along this line is, this person's hubby is a teacher and sits a lot, and we think of the truckers also. Is there an occupational hazard with some of the things we do for the prostate?
For sure. I mean, any job, I guess, for instance, up in the Iron Range, I guess the people that drive the trucks in the mines, those kind of like move and bump you around a lot on the bottom. People that ride horses, I mean, that's a definite risk for prostatic hypertrophy. One thing I wanted to touch on with the TURPs, I mean, several years ago, they came out with that microwave procedure, and I had a lot of patients have that done. I didn't have very much luck with it. How about you?
Yeah, it's been shown now at a lot of double-blind randomized trials that it really does not work, and so unfortunately, there are pockets of people who still do it, and oftentimes there's some sort of financial interest in it. But I think there's plenty of papers that show that it's not a good long-term treatment.
That's the perspective that I found out the hard way.
Is prostate cancer hereditary, and when do you start checking?
Well, there certainly is
what does family medicine say?
Almost the same thing urologists say, I think, and I hope. Yes, there's a familial component to prostate cancer, if it's okay if I jump in a little bit. In general, for men who decide to proceed with screening for prostate cancer, we think of screening starting at age 50. For people with a family history, we think of screening earlier, such as age 40 or 45, and more frequently. And same for, I should add, for black men who are at increased risk compared to white men. If they want to be screened, they should be thought of screening earlier.
Paul?
Yeah.
I agree with Hutch. No disagreement here. Yeah, I think it comes down to, if a man was diagnosed at a young age, that increases your risk overall.
What does screening mean?
Usually with a rectal exam and a PSA either every year or every other year.
One thing to take in mind here too, that the younger you develop prostate cancer, I think the more aggressive the cancer is. So it's very important to, if you have a family history, to get screened very young, and if you detect something, be aggressive.
I want to thank our panelists tonight, Dr. David Hutchinson, Dr. Paul Tonkin, and Dr. James Vodvarka, and our medical students Dan Dutcher, Eric McDaniel, and Marie Whippler. Please join Dr. Alan Johns for a program next week on cancer, when his panelists will be Dr. Bassam Giel, Dr. Dan Nikovich, and Dr. Eric Sather. Thank you for watching, and good night.